Now I request my last speaker, Professor Osman Fahim, for talk on TAVI.
Okay. Assalamu alaikum, everyone. I'm honored to be presenting in front of my esteemed colleagues, and I stand between everybody and break and dinner, so I'll try to stay on time. These are my disclosures. So this is a busy slide. The title of the talk was Indications and Procedural Aspects, but if this is the same, the slide was too big to fit on one side, so basically this is the same algorithm. What I want you to focus on is the age, and I don't know if you can see the dot on the screen, but basically what we're thinking about now in terms of indications is lifetime management of aortic valve disease, not just whether they are going to get one valve or two valves or three valves or whether it should be surgical. We're looking at their age and we're looking at their risk. So it's either high or prohibitive risk, or it's less than high or prohibitive risk. And the age cutoffs are less than 50, 50 to 65, and over 65. If you look at over 65, if a patient is then broken down into age greater than 80, TAVI's class 1 indication, age 65 to 80, both SAVR and TAVI are class 1 indication, and comes down to heart team discussion and patient preference. And age less than 65, they say SAVR, but that's also up for discussion. So this is on the ACC-AHA website, and you should definitely look at it in detail, because you have to think about the patient. If for young patients, their second or third valve. This is another consensus statement that you should look at if you're starting a TAVR program or you're part of a TAVR program, because this tells you what quality outcomes are being measured globally. And so if you look at it, you know, there are in-hospital outcomes such as aborted procedure, conversion to open heart surgery, second valve, cardiac arrest, annular disruption dissection, device embolization, pacemaker. Then there are 30-day outcomes which include rehospitalization, and then 1-year outcomes that include quality of life and all-cause mortality. So again, look at these. It's important to understand what is being measured and what you will be benchmarked against. You have to have a multidisciplinary team which involves interventional cardiologists, cardiac surgeons, imaging cardiologists, cardiac anesthesia, and a long list of support staff that helps create a successful program. You need facilities and institutional resources. What you need to have in your cath lab is have different kinds of access kits, endovascular sheets, going up to 20 French, different guide wires of various thickness and support, vascular closure devices. ProGlide is the one that's used the most, and then both peripheral and aortic valvular balloons and snares in case you run into trouble. So you should have an assortment of devices to get you out of trouble. You're going to think about anesthesia. It's all about pre-procedure planning. So generally, we work with our anesthesia colleagues to figure out if somebody is going to be conscious sedation or general anesthesia. All of our patients are conscious sedation unless there's a strong reason for general anesthesia. Most of the patients are transfemoral access. There's always a cardiac anesthesiologist, not a general anesthesiologist. We don't do any central lines, and there's no Foley catheter, which expedites patient mobility post-procedure. Globally, over 90% of cases are now done transfemorally because the sheet size is so much smaller. About 10% of cases are alternative, and transcarotid and transaxillary seems to be the best way for that. Think about your room setup and what's comfortable and ergonomic for your room. Anesthesiologist is usually at the head of the table, and you're on the patient's right side with your interventional equipment behind you, and then there's a valve preparation table somewhere in the room. For alternative access, if you're going to do transcarotid or transaxillary, the whole team has to shift to the left, and you will be standing at the patient's head, and the anesthesiologist and echo and everybody is pushed off to the left side. So for the actual procedure, you're going to think about it in 5 steps. It's access, crossing the valve, balloon valvuloplasty, that's done in some cases, valve implantation, and then access closure. You notice that access is mentioned twice because these days access is the most common complication. All the other complications have really gotten very minimal with good procedure planning. So we always do a team huddle. Not everybody who shows up on the day of the procedure is familiar with the patient. So cardiac surgery, cardiac anesthesia, us, echocardiographer, the cath lab staff, the surgical techs, everybody is part of the huddle, and we go through each and every detail of the patient before we start the procedure. Everybody has a defined role. And before we deploy the valve, there's a second sign out in which everyone's assigned a role and they go to their positions. And we find that makes it much more likely to have a successful outcome. This is the report you will get from the company. You should be very comfortable looking at CT scans yourself and measure annulus size, coronary height, access size. This report should just be confirmatory for your own assessment. This is not a standalone document. You need to look at it yourself. For access, you're going to measure the vessels, common femoral, on your CT scan and use 1 or 2 ProGlides. So you need to get familiar with using ProGlide devices for pre-closure. Most of the time we use 2, but you can get away with 1 device as well. Temporary pacing is used for almost all the cases. For balloon expandable valves, it's crucial. For self-expanding valves, it's sometimes necessary and helpful. We use a temporary pacing wire, but you can also use a wire in the left ventricle with a clip on it to pace, or you can use a coronary wire to pace the patient. We use self-expanding valves. There's about a 15% chance of requiring a permanent pacemaker post-procedure, and these are the risk factors for that. That includes the traditional risk factors. So the big ones is a pre-existing right bundle branch block or a trifascicular block. Those patients, you want to implant the valve as high as possible to avoid the requirement for a permanent pacemaker. When you're crossing the valve, you use an AL1 or a JR4 with a soft, straight-tipped wire. Then once you're across, you switch out for a stiffer wire, and then put in your pigtail, measure your pre-TAVI gradients, and then switch out for an extra stiff or super stiff Amplatzer wire. Nowadays, there's pre-shaped wires such as the Confida and Safari, and if you have a very horizontal route, or if you have a very calcified valve or tortuous aorta, then a Lunderquist wire is helpful for extra support. This is basically an AL1 pointed at the valve. You're going to use a pigtail as your marker, cross the valve, put the AL1 in, and then switch out for a stiff wire. Your implant angle is crucial. Again, a reason why you need to be familiar with the CT scan. You can either use a tricommissural view or a tricuspid view in which you have the non, the right, and the left cusp all spread out, or you can use the cusp overlap view in which the non-cusp is isolated and the right and left cusp are overlapped. The advantage of this is that the non-cusp is the lowest, and if you're implanting your valve just at the level of the lowest cusp, then you don't have a very low implant and your pacemaker rates really go down. Since we've started doing this, our pacemaker rate has probably gone down from 15% to around 7% or so. BAV is not always required. If a patient's mean gradient is greater than 50, valve is heavily calcified, peak velocity is over 5, then you should do a BAV. Or if it's a bicuspid valve, you should always do a BAV. There are several valve balloon sizes that are available for this. Basically, you rapid pace the patient to drop the blood pressure systolic below 60. You quickly go up on the balloon. You will see a waste because of heavy calcium, and then you'll see the valve crack. Obviously, this carries a risk of stroke as well as annular disruption. So use a balloon size that's 1 size smaller than the mean diameter of the annulus. We can skip this. This is just looking at the catheter delivery system. So there's a nose cone that helps you cross the valve. There's a sheath that encases the valve, and then the delivery catheter. You inspect the valve under fluoroscopy. Make sure the paddles are good and symmetric, and make sure that here you can see there's more separation between this paddle than this, and so it's asymmetric and the valve needs to be reloaded. The other thing when you go up is to keep this port at 3 o'clock position, because that minimizes the chances of your valve obstructing the left coronary or the commissure obstructing the left coronary. I'm going to skip over this. Basically, your first diamond is about 10 millimeters, and you want to be about 3 millimeters below the annular plane. So we slowly pace at about 120 while we're positioning the valve, and once you're 2/3 deployed, the valve is functional. It's important to keep this stiff wire pulled back when you're deploying. If there's a lot of tension on the wire, then it's going to push your valve out. Once the valve is in position, you take a root shot and see if you're happy with the position. You can reposition this 3 times. We've done it sometimes up to 5 times. It works okay, but the IFU is 3 times. So you check for coronary perfusion and you check for valve depth and paravalvular leak. I'm going to skip over that. So immediate post assessment is for rhythm, paravalvular leak, as well as coronary obstruction. You remove the big sheath, you do your pro-glide deployment, and you check your peripheral pulses. If the pulses are good, you give protamine. Post-procedure care, the patients go to the CCU. You should have a protocol for vascular checks, rhythm monitoring, hemodynamic parameters, veno-off inotropic support, check neurostatus, because up until 48 hours they can have a stroke, antibiotic prophylaxis, antiplatelet therapy is usually started the same day, and resumption of home meds and getting out of bed and to chair. Pearls and pitfalls, this is my last slide. Or was supposed to be my last slide. If the diameter is borderline between 2 valve sizes, especially for self-expanding valves, consider the larger valve size. Try to minimize your use of contrast. We cut our contrast 50-50 for all injections. Be very comfortable with per-close usage because, as I mentioned, access is the main complication these days. Don't be too aggressive with your transvenous spacing because RV perforation is quite common. And always be mindful of the position of your stiff wire. So this was kind of a breeze through of a long procedure, but I think it should give you an overview of what the important points are. And do look at those 2 documents that I mentioned because they will help guide your career and your decisions as you start a program. Thank you.
Thank you, Dr. Osman, for excellent talk. Now I request our panelists for a quick comments. Dr. Jabbar, please.
Actually, TAVI is not my field, but I'll talk about peripheral intervention. Madam nicely elaborated peripheral intervention, but 2 things which are very important, acute limb ischemia and below knee intervention. Acute limb ischemia is mishandled. They initially go to the surgeon, and by the time they reaches us, they are already in Rutherford class 3, which means amputation. We have to focus on it, and it is being neglected, and we can see many limbs. And below knee intervention, which is difficult both for interventionalists as well as for the surgeon. Surgeon don't touch it, and for us, the inventory and many things which are now coming to Pakistan, but they are deficient. What Madam showed is nice, but I think less than 10% is available in Pakistan.
Dr. Salia, please.
If I can just make a comment here, I think I completely agree with you, and that is why I chose the FemPop segment, because that is perhaps for our fellows, perhaps the best that they can learn. And our nemesis is always thrombus and acute limb ischemia. And for me and my team, I think we end up getting the worst cases from all over Punjab, and in fact are getting a bad reputation. They either get people amputated because they come to us so late with acute limb ischemia. And people have atherothrombotic complications, basically. There's bad management of the heart and late presentations, these critical limb ischemia. I had a lot of cases, but there was, in the interest of time, I didn't show them. With bad-looking feet, and that is why the Wi-Fi classification is so important, because even if you revascularize them, and that is why I also showed the game changers, because that's the only tool set that we have. But you must know the updates because you're fellows, and we must know the future and its direction, because one day the future can come to us. We may be living in the third world, but we're not living in, 1,500 years ago. So we will probably, hopefully, we should, if we have the thought process, we should be able to get the tools. And if the surgeons don't do it, well, let them not do it, we'll do it. Particularly below knee.
Yeah, and believe me, the acute limb ischemia is not very difficult to deal. All that, you have to put a sheath and catheter and give thrombolytics into the lesions.
But at the right time.
24 hours.
Yeah.
And when you do injection next day or 12 hours to 18 hours, you will see the flow is established and the limb is saved. And we are seeing so many cases, but unfortunately we need to create more awareness.
Dr. Tufail has something to say on that. He does a lot of that.
I agree that we face a lot of thrombus, but usually we study the atherosclerotic disease in the peripheral, but we face that more than 90% we have a thrombus problem. Usually in young age presentation, and there is no proper guideline to the even medical staff that where to send the patient. They keep their patient in their hospital and wait for the line of demarcation. After the line of demarcation, they amputate. This is not the information that we are doing the peripheral intervention, or other centers are also doing the peripheral intervention. And the acute thrombus that we usually give the TPA immediately, and we have a good result. Sometimes we don't have the good result. But for the thrombus management, we don't have the inventory and proper tools available in Pakistan. And there is also cost problem as well. And we also face a lot of thrombus here. Yes. Atherosclerosis is very, very rare here. But rare or maybe late presentation, I usually ignore the old age people in Pakistan.
I agree with you. We are having a devices problem, but in acute limb ischemia, what is recommended? If you just put a catheter, even if you don't have the dedicated catheter, perfusion catheter, you can make your own.
Convert the GR catheter
by making
into
holes
perfusion
in the MP5 or
MP, yes,
which is easy, and you have to occlude the distal end.
Yeah.
So the thrombolytics is
How to
spread
occlude the
into-
distal lumen?
You can stitch it. What I do usually, I stitch it, and I have learned this from Imam Sadiq. He is gifted me.
You stitch the distal hole of the MP catheter.
Yeah.
Imad forgot to tell us that, huh?
And how to reach the regional side?
You can just wire, and because the MP is atraumatic, it will not cause injury. The vessels are usually, for example, if it is SFA or popliteal, it is large enough. It will not be traumatized.
But we think that if we give the TPA exactly inside the thrombus, we have a good result. If we give in the lumen TPA, usually the TPA goes into the collateral vessel. But if we give LITEC in the thrombus, then we usually take the good result.
We had
but
a lot of...
we usually rail on the wire to reach on there. If you stitch the distal lumen and how we reach it within the thrombus, I don't know.
I think we used to have a good inventory of perfusion catheters once upon a time, right? And that really, with different sizes, you see 25, 60, and you could go the whole length. And in times of stress, I have even stuck a catheter into somebody's subclavian axillary artery with just the end hole and given streptokinase, you know, and had a good pulse 6 hours later.
Yes.
But that's not 100% right. The best way is to have a perfusion.
Okay, Duna, I think we are running short of time. I want to thanks all the audience, especially who are over here till this time, all our my speakers and my panelists. Thank you.